Great, Dr. Reynaldo. Let me share my slide real quick. Can you all see and hear well?
Yes, we can see your slides. I'm wondering if you can put it in maybe the presentation mode.
Let me see.
There we go.
Yeah.
That's fantastic. Thank you.
Yeah, if let me get to see, because I have the some of the just if you were to use to present. Let me see. Is it okay if I leave the slide this format?
Yeah, we can still see it, Dr. Dao. We can still see it.
Thank you. So thank you again, the NCI and the Coalition for Global Hepatitis Elimination of the Global Task Force for this opportunity. I title my presentation Joint Actions for Liver Cancer Control in Vietnam to signify the work that I will present is actually a result of a collective effort of multiple people, partners, sectors, both in the US and Vietnam. And I believe for us to continue to make meaningful contributions in the control of liver cancer in Vietnam, we would need to join hands and work collectively and collaboratively. So here's my outline of the presentation. I will provide some background of the liver cancer continuum in Vietnam. I will point out major gaps in the continuum. And to address these gaps, I will share with you all how and what we did as studies and as programs. And finally, I will finish by postulating our future direction towards liver cancer control in Vietnam. So on this slide, as highlighted in the world map, Vietnam is in red, located in Southeast Asia, and it is a low to middle income country with a population of about 100 million. It's a beautiful country where people are also pretty nice, I think. And due to my commitment and work in liver cancer area, I am able to live and work in Vietnam up to 6 months a year for it. And on the bottom graph, liver cancer rates in Vietnam are represented in the left panel, male, and the right panel is representing the female. And for male, liver cancer rate, as you can appreciate, has doubled over the past 2 decades. And for female, liver cancer rate in the country increased significantly over the same period. When we combine the male and female together, liver cancer is the most common solid cancer in the country. It is also the most common cancer-related death in the country since 2018. The adjusted incidence rate, just to give you some perspective, is about 23 per 100,000 in Vietnam for liver cancer. In comparison, the USA has an adjusted incidence rate of about 7 to 8 per 100,000. And as a result, Vietnam since 2018 has the 4th highest burden of liver cancer worldwide out of 195 countries with the liver cancer data reported. And another key point is that the trend in liver cancer in Vietnam is projected to continue to increase in the next 2 decades if there are no effective national interventional program. So on this slide, on the top panel, we use the cancer control continuum framework by the NCI to guide us on how to approach the liver cancer control in Vietnam. From the etiology standpoint, as you can see, liver cancer in Vietnam is primarily caused by infectious agent, specifically hepatitis B. And we all know that.
Sorry, Dr. Dao, I sorry to interrupt you, but is there any way maybe you can increase the size of your presentation?
Yes, let me see.
Because it's very difficult for others to see the information. So, okay.
Yeah, is it better?
Yeah, that is better. Thank you.
Okay. Thank you for pointing it out. In terms of liver cancer prevention in Vietnam, and as we all know, hepatitis B is a preventable disease by vaccinations and facilitation of screening and access to care of those who already been infected. Treatment for Hep C can decrease the risk, but there are residual risks of having liver cancer. So another aspects of liver cancer control in Vietnam is for early detection of those who already have Hep B and also increased risk for liver cancer. So in spite of these, preventable evidence-based practices for hepatitis B, the statistics in Hep B-related liver cancers are still, I believe, startling. As you can see on the bottom left of this slide is an estimate of the liver cancer cases in Vietnam attributed by chronic Hep B infection. So hepatitis B infection is responsible for about 70% of the liver cancer cases in the country. And on the right panel, you can see that liver cancer diagnosis when patients have the symptoms are already at an advanced stage where curative treatments are limited. And in fact, about 70 or 80% of liver cancers in Vietnam are diagnosed at stage 3 or higher. And I highlight the red there. So, so these are the major gaps in liver cancer control in Vietnam, hepatitis B, and the majority of them are diagnosed at a late stage of the disease. So after knowing these gaps, what have we done to help address these gaps? So before I share with you what the studies and the program that we've done, there are two more pieces of information that I like to present to give you a perspective on how we have been able to approach and work in Vietnam. So here is an overview of the public healthcare system and the medical education in Vietnam. And the system is organized under administrative hierarchy with the central level under the Ministry of Health, and the local levels are under the provincial and municipal authorities that distributed throughout the country. And at each level, there's a two-arm system. One arm is focusing on prevention or preventative medicine, similar to the US CDC. And the other arm is focusing on the clinical care services delivery. And there are several key points here. The government maintains a strong concerted effort with both strong public health institution and healthcare capacity, in which the country leadership maintains the key independent determinant in shaping the health policy and implementing public health practices. The primary mechanism that they would be able to do so from the leadership standpoint is through this we call DOHA, or Direction of Healthcare Activities by the Ministry of Health, or the MOH. And the DOHA requires that public health institution at the higher government administration, these higher level, to support and empower the lower levels in the municipal or community healthcare centers in terms of providing public health programming or other community-based activities. And as a result, vertical communication within the healthcare system in Vietnam is pretty seamless and considered effective for healthcare promotion, training, for primary care setting, etc., as well as to educate the public health, especially the mass media. So, and the role of the medical education and public health educational institution is to train and contribute to the critical mass of the public health system in Vietnam. The reason I'm sharing that is that, for instance, in our case, when we work in Vietnam, we wanted to conduct our community-based screening and access to care for viral hepatitis, which I will show you in the subsequent slides. We will have to, for example, in Ho Chi Minh City, the highest authority in healthcare would be the health department of Ho Chi Minh City. And then from there, they would communicate to the commune level health stations so that we would be able to approach the community-based organization health station to implement our public health program. The other background information is that before we approach the liver cancer control problem in Vietnam, we also established two infrastructure and capacities as long-term strategies to help address the issue, the liver cancer public health there. Because we wanted to signify to the local partners that we will come there, we will work with them, we will stay with them for a long term. And for this, the work that I will share with you has been done by the Vietnam Viral Hepatitis Alliance, which is registered in Vietnam, and it focuses on community-based program. And the Center of Excellence for Liver Disease in Vietnam by the Johns Hopkins University School of Medicine is to focus on capacity building, healthcare system, and academic programmings. And to remind you again, for liver cancer control continuum, we are given our expertise and resource we have, we would focus on more on the earlier parts of the continuum, and that would be to prevent viral hepatitis. And for those who already have it, we would focus on the early detection of liver cancer. So going back to hepatitis B, the question we posed at the time were, what were the gaps in hepatitis B continuum in the country? And as you may have been aware, for hepatitis B elimination, we wanted to focus on increasing access to diagnosis and treatment, because for Hep B elimination worldwide, the World Health Assembly endorsed the implementation of 5 core interventions, which have been demonstrated to be high impact, affordable, and cost effective. So in Vietnam, of the 5 core intervention, the 4 measures related to prevention, that would include childhood vaccination, prevention of mother-to-child transmission of Hep B, blood and injection safety, as well as the harm reductions. have relatively been established mostly by the national vaccination program and the HIV/AIDS program. And you may know that Vietnam is one of the beneficiaries of the PEPFAR. So HIV programs has been in Vietnam over the past 2 decades or so. So they are focusing on the other risk groups. For us, the only one core intervention that left neglected was the how to raise awareness, screen and link people who already infected with chronic Hep B infection. So that would be the 5th intervention code recommended by the WHO. The next question we asked was whether the country would have the national policy for hepatitis B screening and treatment and linkage to care. And indeed, Vietnam was one of the first countries in the world that released in 2015 the National Action Plan on Viral Hepatitis Elimination and Prevention. And then our other questions were, what were the Vietnam-specific barriers in the Hep B continuum and in Hep B elimination? And to us, there were several factors that quickly appear. Were one, we need the better data for Hep B. And in fact, in the first National Action Plan of Hep B elimination and prevention in Vietnam, they estimated that Hep B infection was somewhere around 8 to 25% in the country. So, and most of the data was from convenient focus studies. To us, they were not representative data in the country. And then other questions we have include what would be the baseline continuum of care for Hep B in the country? Do we know the level of awareness in community as well as healthcare provider? And whether there were any other Hep B epidemiologic profile that we need to know before we can help address it. So in order for us to address these questions, we launched in 2019 a citywide study to determine hepatitis B prevalence and to characterize the Vietnam-specific barriers that I mentioned. We selected Ho Chi Minh City, the largest and the most diverse city in the country for the study. And Ho Chi Minh City, as shown here, is located in the south of Vietnam. And the middle panel is the map of Ho Chi Minh City. And it has a population of about 9 to 10 million individuals. So on the right panel is the public health sampling method that we deploy. And the method is the probability proportionate to sample size. By deploying it to, we representatively, I think the key term for us here is representatively invite and enroll 20,000 adults 18 years old or 18 years or older throughout Ho Chi Minh City for the study. And the panel on the right is the sampling approach. I won't go into the detail, suffice to say that we selected 100 commutes out of the 320 commutes in Ho Chi Minh City. And in each commute, we invited 200 individuals. And like I said, the study was conducted from 2019 to 2020. And around in the mid of 2020, we had to stop the study prematurely due to the COVID restrictions. So finally, we ended up enrolling 17,600 individual of the 20,000 individual blended. And that would represent 88 commutes out of 100 commutes we initially blended. And following the data quality check-in, we finally had a cohort of 14,765 individuals that with the complete data for final analysis. So that was the research methodology and paper. What does it look like in real life? What happened on grounds? So here I show you a commute health station where representative adults invited in the neighborhood come for the screening event. And as you can see, upon entry, they register and answer the KAP or knowledge, attitude, and practices questionnaires. And then they have their blood drawn. The blood collected, then courier back to central lab for testing and storage. And on the right panel, the middle picture is our outreach team, comprising 4 to 5 healthcare workers, a doctor, and 1 to 2 phlebotomists. One key factor in our program was that we use 3 panel screening tests for hepatitis B. That would include HBsAg, anti-HBs, and anti-cold total. And for the Hep C, we use anti-Hep C antibody. And here are the results of the study. The prevalence of HBsAg positivity in Ho Chi Minh City on average is 7.5%, ranging from 5.5 to 17.5%, depends on the districts. And you can also see that there are there's a variation of HEPI infection rates among the 24 districts in Ho Chi Minh City, represented by the different degrees of the colors there. The gray areas are denoted unreachable size due to COVID restrictions. And on the right panel is the baseline linkage to care that we documented. So briefly, among the 1,157 persons with HBsAg positivity, and that number represents the 7.5% prevalence rate, the prevalence, we had about 70% were newly diagnosed. So that means they didn't know about hepatitis B before they enroll into the study. And about 30% were diagnosed before they participate in the study. So they were already they have already been aware of hepatitis B. And of the 345 individuals diagnosed prior to the study entry, the 30%, 165 of them, roughly 50% of them were engaged in care. And by engaging in care, that is those individuals who sought medical care from primary care provider or specialists in hepatology or infectious disease for hepatitis B management. The of the people who newly diagnosed for hepatitis B through the study, the number was 992 individuals. When after 3 months, when we call them for information on the follow-up, about 300 or 31% we were not able to contact and had the interview. So that left us with 629 individuals, or about 63%, who actually participated in the post-study form interviews. And of those, about 24% or 148 out of the 629 sought clinical care and receiving clinical care management for Hep B after they know they had the Hep B diagnosis through from our study. The reasons, major reasons for those who miss or we missed calling them include that they gave us the phone numbers that did not work or the wrong numbers. And many of them also refused to answer the phone call when we call back. For the people who did not engage in care, major reasons include that they had a busy schedule, they had some other work to do, implying that they may not have been thoroughly educated about the importance of Hep B and Hep B liver cancer. Other two reasons include that they thought they felt fine without any symptoms, so they didn't need to seek medical attention. And another reason is due to financial concern. So on this slide, what I'm showing here is the prevalence of hepatitis B vaccine-induced immunity to hepatitis B among the adults 18 or older in two populations in Ho Chi Minh City. One population is the general population, which is the population that we enroll in the study. And the other population is the non-infected population, defined as those who have never been exposed to Hep B, those who have negative anti-core total antibody. And on the y-axis is the birth year. I know it's a little it's a little to visualize clearly, but what I can summarize is that in the general populations, the one in yellow highlight, what we found was there was a higher prevalence of vaccine-induced immunity in the latter year, the people who were born in the latter years, while among the non-infected populations, the people who were younger had a lower prevalence of hepatitis B vaccination. And on the left panel, it illustrates the prevalence of Hep B naive or those who are susceptible to Hep B infections among the 24 districts in Ho Chi Minh City. And the prevalence range from 30 to 45%. So what about hepatitis C? As I alluded to you earlier, that we also test for hepatitis C. So on the far left panel, the prevalence of anti-Hep C antibody varies among the 24 districts, again, ranging from 0 to 4.7. And the average is 1.3%. And of those who are positive for anti-Hep C antibody, roughly 51% had a positive Hep C RNA. With that said, though, in the Hep C RNA negative group, we also know that about 50% of them reported having Hep C treatment prior to enrolling in the study. So the real rate for positive viremia among adults in Ho Chi Minh City would be around 70%. In the middle panel is the Hep C prevalence by the age and the gender versus the birth year. And here you can see that in the what we call the Vietnam birth cohort, those who were born between the year 1945 and 1964, this birth cohort comprises about 40% of all Hep C cases in Ho Chi Minh City. And on the far right panel is the baseline linkage to care or the care continuum of hepatitis C in Ho Chi Minh City. So in this study, we had about 300 study participants with positive anti-Hep C antibody. And you can see that about 28.5% of them reported knowing Hep C prior to the study entry. And of those who knew before they entered the study, most of them, like 78%, were coincidentally diagnosed with Hep C in routine health check checkup or doctor visits, or when they admitted to hospital for different reasons. And of those who were aware of hepatitis C diagnosis, 82.7% of them initiated treatment. And of those who initiated on Hep C treatment, 53.6% of them had reportedly had a cure for Hep C. And we already disseminated this result scientifically. Next, what about viral hepatitis in healthcare workers in Ho Chi Minh City? So to answer this question, we, in a pilot fashion, conducted a mixed method study involving 203 healthcare workers for an HPV and Hep C serological evaluation, knowledge, attitude, and practice survey, as well as in-depth interviews. So we recruited this cohort as a representative sample of healthcare workers out of 4,000 healthcare workers in Ho Chi Minh City healthcare system. And as you can see here, the results are following. In this pilot study, 10.5% of them were infected with actively infected with hepatitis B, HBsAg positive. 0.5% of them had anti-Hep C antibody positivity, and about 28% of them had positive anti-Hep C core total antibody. 75% of healthcare workers in our study demonstrated adequate anti-HBs antibody, adequate immunity, defined as 10 IU per ml. And 50% of them, of the healthcare workers reported that they not, only 50% of them reported that they always using gloves for clinical activity involving handling of blood or bodily fluid. So another 50% did not do it all the time. So, and then the other key finding in this study was that in the in-depth interviews of 28 healthcare workers, we reviewed two major concerns for most of the interviewees. The first concern is the need for financial support for Hep B and Hep C screening and treatment in healthcare workers in Ho Chi Minh City, and the need for HPV-specific guidelines to be independently developed. Because right now, the guidelines for viral hepatitis in healthcare professionals is not available. And most of the medical centers in Vietnam use the HIV guidelines instead. So up to this point, what I have shown you was the low education awareness of viral hepatitis in community, in healthcare providers. And another piece of data that I did not show was that in our surveys from the community, about 67% of all the participants reported that they would consider use some sort of rapid test, like a point of care rapid test for Hep B and Hep C diagnosis if offered. In order to, for us
Sorry,
to—
Dr. Dao, sorry to interrupt you. This is Joanne again. I just wanted to give you maybe a 2-minute warning that your presentation should be coming to a close shortly. We want to make sure that we stay on track and that we still have time for the last speaker as well, Dr. Kirk. Great,
thank you. So I will. So in order for us to respond to these deficiencies in education in various target group, we launched a comprehensive educational program focusing on the really basic information about viral hepatitis and liver cancer. And we also did that at the multiple levels, from community to primary care settings to a liver specialist and researcher. And in the subsequent slides, I wanted to show you some of these programs that we've done. This is for healthcare providers. And this is some of the community-based programs that we deploy to increase the community awareness and to help destigmatize hepatitis B in community through this healthy liver, happy life health fair. And these are some of the pictures we capture. And this is before these community-based event, we did produce short video clips to disseminate in various media outlets. This work was in collaboration with the WHO office in Vietnam. And here are some of the community-based program again. These are the programs that July 28 every year, we organize viral hepatitis scientific programs to commemorate the day. We invite the experts in Vietnam and abroad to participate. And then we also have a liver talk programs to focus on the trainees, the researcher in viral hepatitis. And this is the work, as I alluded to, that we wanted to promote point of care rapid tests in primary care setting. And here is a pilot program being implemented in 3 sites in Vietnam. And the next few slides is what we have done to address the gaps in the late stage of Hep C diagnosis, HCC diagnosis in Vietnam, is to focus on the early detection methods and tests. And if you look at the evidence-based practices for early detection in Vietnam, you can see here ultrasound is already available in the district level. However, we still see about 70% of those who first time diagnosed with liver cancer presented at a late stage. So we thought the situation would be more complex and deep-seated. So we take one step back to propose to do a comprehensive analysis of the situation, and that work is being planted. In parallel with that work, we also launched a 5-year prospective international observational study for HCC early detection and high-risk individuals using liquid biopsies, and the study is called Stop HCC. And this work, we collaborate with the Saudi college because we know that they have a different risks of liver cancer. They have mostly metabolic risks for liver cancer. So I wanted to finish with this slide. What would be the future direction for us? I use the star here to signify that we hope that the future would be bright. And the star also has 5 points. In the first point, we wanted to focus still on the capacity building by strengthening and expanding our research capacity in research methodologies. We wanted to involve in academic, to work with academic and medical and public health institution, as well as the private industry, so that we can develop a co-financing model like public-private partnership. We wanted to leverage capabilities that built during COVID. For example, the telehealth system in Vietnam certainly developed really robustly during COVID. Maybe we can use that to communicate to do the training capacity building in the primary care setting. We wanted to also promote and integrate evidence-based interventions in primary care setting in terms of Hep B screening, access to care, and early detection method. And then the other really important factor is advocating the local government to take on this public health issue. And we wanted to develop a task force comprising of experts from community, various stakeholders, NGO, etc., so that we can promote for science for policy. And finally, what I have not shown you, but you may have realized that the data, for example, that I cite from Vietnam, mostly were from single or several center base. They don't have a unified a surveillance unified system yet for viral hepatitis and liver cancer. So we wanted to, this is for a long term, that we wanted to work with them to strengthen the surveillance system for viral hepatitis and liver cancer to be more effective, efficient with an interoperable linking network. And for this work, we anticipate it will take decades. And the lesson we learned was that in the HIV arena, for example, with the relatively a lot more resource in HIV than viral hepatitis in Vietnam. Like I said, HIV program has been a beneficiary of the PEPFAR program, and it took them almost 20 years to have a well-established surveillance system.